good morning. Today's session is on the title Neurotoxic Snakebite Management with focus on Krait bite. This session was developed for the Shaheed Hospital in Dalli, Rajhara in Chattisgarh because we're seeing a large number of Krait bites. But it is relevant to all hospitals which face neurotoxic snakebite. On the right side of the slide, you can see a poster that was an award winner for the World Snakebite Awareness Day poster competition on climate change and snakebite. September 19th is the World Snakebite Awareness Day, and our clinical unit conducts poster competitions for schools and colleges to create awareness about the problem of snakebite. I would like to start off with a case, a 26-year-old farmer from Arcot who woke up to a sharp stinging pain on the right ear at 2 a.m. He saw a black snake crawling away. He was sleeping on the floor. He had generalized body pain, chest discomfort, and breathlessness. In the local hospital at 3 a.m., he was treated with 10 vials of anti-snake venom. He noticed difficulty in opening eyes with weakness of all four limbs at 5 a.m. He was referred to CMC Vellore. At admission, he had ptosis and proximal muscle weakness. There was no signs of local envenomation. The emergency department, his breathing was shallow. There was progressive worsening of the upper and lower limb power. He was intubated in the emergency department and shifted to the ICU. He received 10 more vials of antivenom. He improved after this and he was extubated in 72 hours. The snake which bit this patient was the Common Krait, and we can recognize it by the black snake with white bands. And the Common Krait has enlarged hexagonal scales along the spine, as you can see in the bottom right diagram. This patient was diagnosed to have krait bite because of the clinical features of being bitten while sleeping on the floor, no local envenomation, abdominal pain and paralysis, and normal clotting. In this presentation, I will focus on the envenomation syndromes, the Bungarus genus and its diversity, the habitat and behavior of the snake, the venom composition and toxicity, clinical features and their response to treatment, and finally, prevention. The envenomation syndromes, according to the WHO Southeast Asia guidelines, there are 5 envenomation syndromes. Of these, the ones which have neurotoxicity are the syndrome 2, which is the Russell's viper envenomation, where there's local envenoming with bleeding or clotting disturbances, shock or acute kidney injury, ophthalmoplegia, and dark brown urine. The 2 pure neurotoxic syndromes are syndrome 3 and 4. In syndrome 3, which is the cobra bite, there is local envenoming with paralysis. In syndrome 4, there is paralysis with minimal or no local envenomation, and this indicates the krait bite, as this particular patient had. There is also a syndrome of paralysis with dark brown urine and acute kidney injury, which is seen with the Bungarus niger, a subspecies of Bungarus which is seen in the northeast of India. This is again the 4 envenomation syndromes that we see. One of pure hemotoxicities which we see with saw-scale viper, the Russell's viper syndrome, where there's hemotoxicity, acute kidney injury, and neurotoxicity, and the common krait of Bungarus caeruleus, where there's neurotoxicity without local swelling, and the Indian cobra or naja with neurotoxicity with local swelling. In CMC Vellore, in a retrospective study of 157 patients, The dominant species was Russell's viper, where there's hemotoxicity, acute kidney injury, and neurotoxicity, and this is about 60%. About 80% of the snake bites that we see are viper bites, where there are these first two syndromes. About 20% of our patients are pure neurotoxic syndromes, and we see more commonly Indian cobra and then the krait bite. Now, the genus of the common krait is the Bungarus genus, and the word krait is derived from the Hindi word karait, which means black. The genus word, that's ceruleus, Bangaram, is derived from the Telugu word Bangaram, which refers to gold, referring to the bands. Bangaras has 8 to 9 species in India. Of these, the most important are the Bangaras ceruleus and Bangaras niger. And these are the venomous snakes. Uh, there are 8 species are understood to have been derived from a common phylogenetic ancestor about 32 million years ago. If you look at this map of the distribution of the Bangaras species, we see that the dominant species across the Indian subcontinent is in the yellow-orange, which is yellow. And we see on the right side in the dotted green are the Bangaras niger, which is there in the northeast of India. The Bangaras ceruleus or the common krait are medium to large size snakes which have a nocturnal character. And the Bangaras ceruleus is the dominant species in India. They are shy snakes generally. In the night, when they hunt, they may turn aggressive and they have a hissing sound. They usually dwell in agricultural fields and near human dwellings, and their prey are rodents such as the mouse, and they may eat other snakes, including kraits, lizards, and amphibians. So the community which is susceptible to the krait bites are the rural community, and usually people who are living in huts, which are close to forests or water bodies where the snakes hunt at night. Now, the krait venom has both enzymatic and non-enzymatic toxins. On the left side of the slide, you see a large number of toxins which are both enzymatic and non-enzymatic. And I'm not going through the details of the individual toxins. But in the krait venom, there are 3 types of neurotoxins. The alpha and the kappa Bangara toxin, which are 3-finger toxins. And these are non-enzymatic toxins. Then you have the beta Bangara toxin, which is a phospholipase superfamily, which are enzymatic toxins. So the alpha Bangara toxin binds to the postsynaptic acetylcholine receptor and blocks the neurotransmission. And the beta Bangara toxin, which is the most important toxin in krait bite, is a dominant constituent of the venom. More than 20% of venom has beta Bangara toxin. Now, the beta Bangara toxin irreversibly binds the presynaptic junction and affects the voltage-gated calcium and potassium channels and prevents the release of acetylcholine. So the main effect of the krait bite is through the beta Bangara toxin and its effect on the presynaptic junction of the neuromuscular junction. We also know that across India, there are intra-species geographical variation of venom, which is a phenomenon to be considered. Now, the mechanism of krait bite toxicity, as we've talked about, is the beta Bangara toxin. And we see in this diagram and the arrow that the phospholipase of the beta Bangara toxin binds the voltage-gated calcium channel and thereby inhibits the release of acetylcholine from the presynaptic terminal. This toxin also shows signs of irreversible physical damage to the neuromuscular junction and the presynaptic junction becomes devoid of synaptic vesicles, following which there's a degeneration of nerve terminals. So there is irreversible binding. There is also make the synaptic vesicles which disappear. There is damage to the presynaptic terminal. And these changes indicate that the toxin of crate bite can't be reversed because of the irreversible binding and the physical damage. And the recovery of neuromuscular transmission is dependent on the regeneration of the terminal, which takes a few days. Now we look at the clinical studies of crate bite. This is one study from Sri Lanka where it was done in the Anuradhapura General Hospital, where there were 210 patients with suspected crate bite over 3 years, and about 50% had the snake identified. 50% of patients required mechanical ventilation for a mean duration of 2 days, and all the snakebite cases were bitten on the floor while sleeping at night. The cardinal presenting symptom was abdominal pain, and 70% had altered consciousness and 17% deep coma. 71% had hypokalemia and 50% had metabolic acidosis. Following the envenomation and recovery, 40% had anterograde memory loss. They couldn't remember what happened, and 22% had peripheral neuropathy. And in this study, the Indian polyvalent antivenom had no significant effect in reversing the paralysis and the ventilatory requirement, and 7.6% of patients died. This is a review of crate bites seen in Sri Lanka and southern Nepal. And the main findings in this review that the crate bite patients were young, they were male, they were farmers, they were bitten in the rainy season. The bites were nocturnal while sleeping on the floor. They were mostly lower limb bites, although there were also upper limb, trunk, and head and neck bites. And the rate of death was between 6 to 12%. All these indicate that a crate bite is a lethal disease. It's bitten at night, so patients may seek care late. And the importance of mechanical ventilation in the management of crate bites. In an epidemiological study of snakebite in West Bengal, which was done between 2009 and 2010, in a population of about 2 million patients, they surveyed this whole community and found that uh, uh, there were 184 deaths, and of these, 66% or two-thirds were due to crate bite. All the crate bites had a common history of sleeping on the floor at night, and it's also important to note that 158 deaths occurred out of the hospital. So the most of the deaths occurred out of the hospital. Most of the deaths were due to crate bite. And we know that across India, the crate bites is the second most common cause of death in snake bite after Daboya Rasali bite. Now, when we look at the clinical profile of neurotoxicity between the three envenomation syndromes, we see that in Russell's viper bite, there is predominantly ptosis, ophthalmoplegia, and bulbar weakness, but low rates of respiratory muscle weakness and limb weakness. It predominantly affects the cranial musculature. On the other hand, in crate bite, we see that 66% had respiratory muscle weakness. We see also in cobra bite that there is respiratory muscle weakness, but less than in crate bite. So these are some of the differences in the neuroparalysis between the three syndromes. The studies also show that crate bite has a longer duration of ventilation than cobra bite, which reverses with antivenom and neostigmine treatment. Now, the treatment studies. So one of the treatment studies was in Sri Lanka, And this study was a cohort study which was looking at the response of crate bites to antivenom and neostigmine, and also the study of electrophysiology. So in this study, there were 33 patients with crate bite. 8 had no neurotoxicity and normal EMG. So they were like dry bites. There were 8 who had mild neurotoxicity with doses and normal single fiber EMG. 6 received antivenom and recovery happened in 20 to 32 hours. So they didn't require mechanical ventilation. 17, about half, had severe neurotoxicity, rapidly descending paralysis, ophthalmoplegia, facial, bulbar, and neck muscle weakness. All these received antivenom therapy a median 3.5 hours post-bite, and studies to measure the antigen showed that the venom was cleared from the circulation after the antivenom administration. Despite the clearance of venom, the paralysis worsened, and the single fiber EMG showed marked increased jitter and neuromuscular block, which improved only in 24 hours. So the antivenom, though it cleared the venom, did actually the paralysis worsen, and this was also demonstrated by EMG. And the muscles recovered in ascending fraction, and patients were extubated at 96 hours. And at discharge, median 8 days after, they found that there was mild single fiber EMG abnormalities which persisted up to 6 weeks. So the study shows that the in crate bite, the although antivenom clears the venom, the paralysis progresses because of the irreversible binding of the beta bungarotoxin to the presynaptic junction, and this cannot be reversed with uh, either antivenom or neostigmine. The one randomized controlled trial in the Indian subcontinent was a study done in Nepal, and in the study they compared low dose and high dose antivenom. In the low dose, there was 2 vials of push followed by 4 vials repeated 3 times based on the clinical response for 12 hours, followed by 2 vials every 4 hours till recovery. In the high dose, they were given an initial dose of 10 vials followed by 5 vials. And in both groups, the ceiling dose was up to 30 vials in both arms. And the outcome was death or the need for mechanical ventilation. In the study of all the neurotoxic snake bites, 43.5% met the primary outcome, and this rate was similar. There was no significant difference between the low dose and the high dose. And the mean number of vials used was similar between the treatment groups in the low dose and the high dose. But what it was found in the study was that patients who were bitten by kraits did worse than those bitten by cobra. So we look at the primary outcome was 26% in cobra bites, whereas 68% in snake bites, in the crate bites. And the antivenom dose in crate bites was also high, 18.3 vials compared to 8.9 vials with cobra bites. So this study showed that even when we give higher doses of antivenom, the in crate bites actually the outcome does not improve, and they have higher rates of ventilation. Now, there was another study done from PGI Chandigarh on the effect of neostigmine in crate bite. And in this study, the patients were given 10 vials of antivenom and 3 doses of 2.5 milligrams of neostigmine at 30-minute intervals after atropine. So 72 patients were recruited in this study, and the median time interval was for administration of antivenom and neostigmine was 4.5 hours after bite. The study, none of the patients showed improvement with this treatment, and all developed respiratory paralysis requiring mechanical ventilation. Despite this, 70 patients survived. And the conclusion of the study was that neostigmine was ineffective in reversing or improving the neuroparalysis. This is important to understand because neostigmine inhibits the acetylcholinesterase and increases the acetylcholine level in the synapse. So it is effective in cobra bite where the toxin binds to the postsynaptic junction. So when you give neostigmine, the acetylcholine in the synapse increases and displaces the toxin from the acetylcholine receptor, reversing the paralysis. On the other hand, in Krait bite, because the toxin effect is presynaptic, there is no release of acetylcholine, and therefore neostigmine does not reverse the paralysis. So in Krait bite, neostigmine is not useful. So in summary, the management of neurotoxic snakebite involves identification of the clinical syndrome, a clinical assessment of the Glasgow Coma scale, the respiratory rate, the work of breathing, neck holding and single breath count, and motor power. And when you see the patient, the first and most important step is to stabilize the patient. So if the person is having hypoventilation, apnea, or paradoxical breathing, the immediate step is actually to secure the airway and to intubate the patient. In South India, we would do the whole blood clotting test because we have to rule out Russell's viper. But in North India, where there's predominantly neurotoxic snakebite, this may not be done in a clear-cut case. So as soon as we can, after the admission, patients must be administered 10 vials of Indian polyvalent antivenom as soon as possible and follow up the patient. And if the neurotoxicity is not improving or worsening, we need to repeat the dose of 10 vials within 1 to 2 hours. If we are not sure whether it's a cobra bite or crate bite, we can try a drug called adrefonium, which is a short-acting drug, and it's given as 10 milligrams with 0.6 milligrams of atropine, and we see if there's any response of the doses. If there is, we can start on neostigmine. If adrefonium is not available, we can start on neostigmine and give 3 doses and see if there is improvement. The dose of neostigmine is tablet neostigmine 0.2 to 0.5 to 2 milligrams Q1 to 3H up to a maximum of 10 milligrams in 24 hours. And there is a different dose in children, and we see the response. If there is a response, this can be continued. And as I've said earlier, the priority is to decide on the need for intubation mechanical ventilation, which will be discussed in the next presentation by Dr. Binila. So in a patient who has mild paralysis and is not requiring intubation, we can start on neostigmine and assess the response. On the other hand, if the patient has already been intubated, there may not be any role for giving neostigmine. So, the dose of antivenom in India for neurotoxicity is 10 vials stat and reassess. And if there is no improvement or worsening, we need to repeat the dose in of 10 vials. This is the dose that is recommended both in the Indian snakebite guidelines and the WHO Southeast Asia guidelines. The role of higher doses of antivenom in management of neurotoxic snakebite is not very clear. One must also say that the dose is based on empiric studies and not based on any dose finding studies or randomized controlled trials. So how is this dose of antivenom derived? So it's based on the amount of antivenom that neutralizes a given amount of venom. So if you look at the literature that comes with each vial, 1 ml of antivenom neutralizes 0.6 mg of Indian cobra venom, 0.45 mg of common krait venom, 0.6 mg of Russell's viper venom, and 0.45 mg of sawscale viper venom. So if the calculated average amount of krait venom that is injected per bite in experimental studies varies from 20 to 114 mg. Therefore, the amount of antivenom that is required to neutralize a krait bite may vary between 44 to 250 ml. And the suggested guideline is to give 20 vials of antivenom both for cobra bites and krait bites. Now, the indications for antivenom therapy in general are the evidence of hemotoxicity in the case of viper bites, either sawscale viper or Russell's viper bite, neurotoxicity of ophthalmoplegia or paralysis, acute kidney injury, rhabdomyolysis, cardiotoxicity, or rapid extension of the local envenomation. And we must remember this. And some of the toxicities may not be reversed, like acute kidney injury or rhabdomyolysis. And in the case of neurotoxicity in krait bite, the administration of antivenom, we take 1 ampule of lyophilized antivenom, reconstituted 10 ml of sterile water, and there are two methods of administration: IV push at not more than 2 ml per minute, or ASV diluted in 250 to 500 ml of saline or 5% dextrose and infused over about 1 hour. The second is the usual way of administration. We recommend administration of prophylactic adrenaline, that is 0.25 mg of 0.1% solution, even subcutaneous, before giving antivenom, and this reduces by at least 50% the risk of severe antivenom reaction. And it's also important to note that before giving antivenom, we must keep 1 ml of adrenaline, 1 in 1000, loaded and ready to be administered in case of anaphylaxis develops. So how do we manage antivenom reactions? So if a person is starting to develop itching, swelling of the lips, mouth, or bronchospasm, we need to slow or stop the antivenom infusion. And if there's evidence of angioedema, that is facial swelling, lip swelling, breathing difficulty, or shock, we need to give injection adrenaline 0.1%, 0.5 ml IM. And we need to repeat this dose every 5 to 10 minutes if the reaction persists or worsens. In all antivenom reactions, we also give chlorpheniramine maleate. The dose is 10 milligrams in adults, and hydrocortisone 100 mg in case of antivenom reaction. If the patient is in shock, then we need to make the patient supine, elevate the legs, and start on saline replacement. And if the shock is not reversing, then we may consider IV adrenaline infusion. For bronchospasm, we give nebulized salbutamol, and once the anaphylaxis is resolved, we reassess the situation and decide on the need for continued antivenom therapy. But if we were to restart the antivenom, we must give it slowly with careful monitoring. Lastly, the importance of prevention education regarding snakebite. So all patients, once when they're going to be discharged, we go through preventive education, the main messages of using a torch at night, making sounds on the ground with stick or feet while walking in the dark, not to sleep on the floor, use of mosquito net, a good lighting around the house at night, space between the house and surrounding vegetation, and not to keep food in areas where people are sleeping. And on the right side is a diagram which was prepared for community education by Dr. Bavaskar, who is an authority on snakebite, is emphasizing here the importance of sleeping on a cot and use of the mosquito net. And both these together reduce the risk of particularly krait bites, and they prevent, with the use of mosquito net, not only prevents malaria, dengue, and other mosquito-borne infections, but also prevents snake bite. So, as a clinical unit, we have an important role in snakebite education and prevention. So, our hospital team visits snakebite patients following the bite at home to understand the risk factors and use the patient as a peer educator to educate the local community. And the picture on the bottom side is one example of a camp that we conducted nearby a patient's house. We also conduct a snakebite survivors meeting once a year, where we invite all the patients who have been bitten by snakes and it's education, and to encourage them to be peer educators in their local communities. We also go to the schools and conduct school education and prevention of snake bites. And it's a very important point that snakebite prevention has to involve affected communities, and as local hospitals, we need to follow up patients to their home, engage with local communities, because essentially snakebite is a preventable disease and snakebite deaths are completely preventable. So I would like to conclude by emphasizing the importance of recognition of the clinical syndrome, of assessment of the patient, uh, and a stabilization, starting on antivenom therapy, on deciding on need for mechanical ventilation, and that the once the patient has recovered, we need to go through preventive education and use the patient as a vehicle for prevention in the community. Thank you. This presentation will be followed by Dr. Binila Chacko's presentation on the respiratory and ICU management of patients with neurotoxic snake bites. For all of you who are listening, the unit I come from, Medicine Unit 1 in Christian Medical College, Vellore, runs the Poison Control Center, and we offer 24/7 helpline for patients who are anywhere in India who are dealing with poisoning or envenomation. The public or doctors or health professionals can contact us by these numbers for the clinical management of any problem cases that you're encountering. Uh, Nurses work with doctors to give you an informed opinion about how to manage the case, and we also will follow up with you. So please access our center in case you need it. Thank you for listening.
Good morning. This is a follow-up of the talk by Dr. Anand Zachariah on the clinical manifestations and how to manage neurotoxic snake bites. Now, my talk is on ventilation in neurotoxic snake bites in resource-limited settings, and I have based this talk based on the questions that have been raised by the participants with specific regards to ventilation in neurotoxic snake bites. I'm Dr. Binila. I'm currently heading the unit of critical care at CMC Vellore. So in this session, we will be looking at these different aspects, practical aspects of ventilation in neurotoxic snake bites. The first one with regards to whether we can use NIV, non-invasive ventilation. When should I put an advanced airway? What mode of ventilation should I use? What sedation protocol should I use? And when should the patient be extubated? So the very first question that we're going to deal with is whether we can use NIV or non-invasive ventilation for respiratory failure in neurotoxic snake bites. Now, while there are a few case reports which have shown the ability to use NIV for respiratory failure, I think one thing we need to remember is there's no harm in trying, but we need to make sure that there are absolutely no absolute or relative contraindications to using non-invasive ventilation in these patients. So if you look at an absolute contraindication for non-invasive ventilation, now this is as for any other patient who is being managed in the emergency department or in the intensive care unit. If a patient has an immediate or impending need for intubation and invasive ventilation in the setting of worsening respiratory failure or an impending respiratory arrest, please do not try using NIV for these patients. Additionally, if the patient cannot maintain airway, a lot of our neurotoxic snake bites have secretions inability to cough and safely protect their airway, or if they have upper airway obstruction because of any reason, maybe a reaction to ASV, if they're claustrophobic, anatomical challenges for application of the NIV interface, or if a patient has worsening shock with increasing anatropes, these are all relative contraindications to using NIV. So please remember that while you may give a trial of NIV based on a few case reports, please make sure that that it is safe to continue the same and ensure that there are no contraindications for continuing non-invasive ventilation in neurotoxic snake bites. More often than not, by the time a patient presents to the hospital with a neurotoxic snake bite and respiratory failure, most of the time they do have their gag and cough reflex is affected. They have pooling of secretions, and most of the time you will not be able to safely apply non-invasive ventilation in this group of patients. So as mentioned in the previous slide, if you have a patient with worsening respiratory muscle weakness, worsening respiratory failure, with or without bulbar weakness, you should consider invasive ventilation. Now, in the resource-limited setting, how do you actually recognize that the patient has all of these problems? Many centers may not have access to arterial blood gas, where you can check for carbon dioxide retention and respiratory acidosis. So how can you clinically make out that a person needs invasive ventilation? So I've just put together some signs of respiratory muscle weakness, which you can monitor for your patients with neurotoxic snakebite, and which may give you an indication that they could potentially need invasive ventilation. So if you have a person who's rapidly breathing using accessory muscles, if the patient has shallow or paradoxical breathing, poor chest expansion, single breath count is something that we monitor quite often for patients with snakebite. If they're able to count less than 15 or unable to lift their head off the pillow for more than 5 seconds, then this patient definitely has features of respiratory muscle weakness. In terms of impending respiratory muscle respiratory failure, most of you will have a monitor with pulse oximetry, and if your saturation on the pulse oximetry is less than 92% despite maximal oxygen, if the patient is either tachypneic with a rate more than 30 or bradypneic with a rate less than 10, that is an indication that the patient is potentially going to need invasive ventilation. Additionally, one thing which you can check for in your patients in the ED or in the ICU is to look for features, clinical features, which will suggest that the patient has a respiratory acidosis. So you can clinically monitor the patient as to whether the patient has an asterixis or a flap. If the patient is becoming progressively drowsy, maybe a wide pulse pressure, all that could suggest that the patient has type 2 respiratory failure. As mentioned earlier, bulbar weakness is very common in patients with neurotoxic snake bites. These patients may have difficulty swallowing, nasal regurgitation, and a weak cough. In any of these conditions, and as I mentioned earlier, all of these conditions may occur in patients with neurotoxic snake bites. You must consider intubation, early intubation, and invasive ventilation. Now, with regards to the question that was raised on the mode of ventilation, which mode of ventilation should I use when I intubate the patient? Now, I've just provided a screenshot of multiple modes which are available on ventilators. And one thing to remember is, in any condition in critical care, there's no evidence to suggest that one mode is better than the other. So please use a mode with which you are most comfortable with. In general, what we suggest for patients in neurotoxic snake bites, because they are quite weak when they come in, either due to Krait or Cobra, better to start with a controlled mode of ventilation, either volume controlled or a pressure controlled mode of ventilation, whatever you're comfortable with. The most important thing is you need to make sure that the ventilation is safe for the patient. So in a person, let's say, who's got an ideal or predicted body weight of 70 kilos, you would want to set the tidal volume at 6 ml per kilogram, which will work out to 420 ml. Okay, and we need to make sure that the patient has adequate ventilatory settings, which will take care of oxygenation. And just a very brief overview into what takes care of oxygenation, that is your fraction of inspired oxygen and your positive end expiratory pressure, which keeps the alveoli open at the end of expiration. With regards to carbon dioxide removal, we know that alveolar ventilation takes care of carbon dioxide removal, and that is essentially your respiratory rate and your tidal volume. So your tidal volume and your respiratory rate, both of these will take care of carbon dioxide. So these are things which you will need to set. So in the control mode, this takes care of your CO2 removal. Once a patient starts breathing spontaneously, this setting called the pressure support will help in generating tidal volume for the spontaneous breaths and will take care of carbon dioxide removal. I just want to highlight one more thing in this setting, which you can see here. So you can see here the rate and tidal volume take care of carbon dioxide, the FiO2 and PEEP take care of your oxygenation. You need to appropriately set your inspiratory time. In general, the teaching would be maybe to set an IE ratio 1:2. And as I said here, the pressure support is for the spontaneous breaths, which take care of the carbon dioxide. One thing which is a glaring problem here in the setting is what we call the flow trigger. So the trigger is essentially telling the ventilator that the patient is trying to breathe. Okay, so you don't want the patient to work too hard to tell the machine that the patient is trying to breathe. So this setting of 5 is very, very high, and you don't want the patient to draw in 5 liters of air before which the ventilator will support with the pressure support. So in general, set the flow trigger at 2 liters per minute. You can use flow or pressure trigger. Flow trigger is generally preferred because it decreases the work of breathing. So what do you monitor and target when you have a patient on the ventilator? I think the key thing, even if you do not have a blood gas, the 2 years that I spent in a mission hospital after my BPS, I had no access to blood gas while managing intubated patients. And the main thing that I was monitoring was the saturations and the work of breathing clinical examination. So ensure that the saturation is between 92 to 94, and you can titrate your FiO2 settings to achieve the saturation of this goal. As I mentioned earlier, ensure safe ventilation strategies in terms of your tidal volume of 6 ml per kilogram. And when you are weaning, I think the most important thing here, and this is actually what you call the pressure time graphic that you can see here on the top half of the screen. Okay, what you can see here is that every breath is controlled. You will know if the patient is triggering if you see a negative dip in the pressure time graphic. So if it becomes like this, you see a negative dip, that means the patient is trying to breathe, and this patient will then be supported by the pressure support, which we talked about earlier. So keep watching for those triggered breaths. Nowadays, a lot of ventilators will come with a little arrow or a little indicator, maybe a triangle or a square, to kind of tell you that the patient is breathing. And when you see the patient is breathing, you can start weaning the ventilator rate down, get it down maybe to 8. And once you bring down to maybe 6 or 5, you can switch to a spontaneous mode. But whenever you wean any setting, please watch the patient's work of breathing. If the patient is working very hard and is very tachypneic with low tidal volumes or very high tidal volumes, you know that the patient is not tolerating the weaning process, and you'll need to go back up on the supports. So this is how you wean ventilation. And while you are, in addition to monitoring your oxygenation, please monitor sensorium and blood pressure. As I mentioned earlier, if the patient's sensorium drops, while on the ventilator with wide pulse pressure, there's a possibility of zero retention. You may need to go up on your settings then. And please ensure that you do not over-sedate these patients with snake bites, because recovery generally happens within 1 to 3 days of ventilation. So this is what we use here at CMC while we monitor patients to ensure that we are not over-sedating them. This is the Richmond Agitation and Sedation Scale. And we try and keep our patients at a Richmond Agitation Sedation Scale of 0 to -1, where they are either alert and calm or just mildly drowsy, but they are arousable. This way, if you do not over-sedate, once they're ready to get extubated, you can safely extubate them. In terms of what do you use for sedation, now there are different protocols which are available, and the sedation that you use depends upon what you have in your setting. It is no different to managing any other intubated patients. In general, what we prefer is a combination of opioids and benzodiazepines. So you can choose either midazolam or fentanyl infusion or morphine infusion, whatever is available for analgesia, but just make sure you do not over-sedate the patient. Now, when do you extubate the patient? That's the last question that was asked. In a center which does not have access to arterial blood gases, I think the most important thing is, again, based on your clinical examination, has the patient's neurotoxic the snake bite effects of the neurotoxic snake bites, has that worn off? Is there reversal of the paralysis? Is there return of respiratory muscle strength? Now, how do you know that clinically? This is a common acronym that we use in critical care, which is the ABCD, which you can use even in the setting of snake bites. So please ensure that the patient has got a good cough and a gag reflex in terms of the airway. Make sure that there's no evidence of edema when you deflate the cuff after suctioning the mouth. There should be a cuff leak. In terms of breathing, on minimal ventilator supports, that is, let's say the patient is on a SPONT mode of ventilation, and the FiO2 requirement is less than 40%, the PEEP is 5 to 8 centimeters of water, and the pressure support is 7 to 10 centimeters of water. This would be described as minimal ventilator supports. As I mentioned earlier, this is a patient on SPONT mode of ventilation. And in this patient, the patient is breathing comfortably. There is no paradoxical breathing. There's no increased work of breathing. The saturation is maintained more than 94%. These are indicators that the patient's respiratory muscle strength is probably returning. In terms of circulation, the patient needs to have stable hemodynamics. It's not that the patient needs to be off inotropes. It may be on a low dose inotropes. That's okay, as long as you've got a stable hemodynamics and the patient is alert and has got evidence of good organ perfusion. In terms of disability, check if the patient's awake, following commands, able to lift the head off the pillow for more than 20 seconds. Again, this is an indicator of reversal of paralysis. So once you have confirmed all these points, it is possible to consider extubation. And just a few tips before you extubate: stop all the sedation, allow the patient to completely awaken, suction the airway and the mouth, and as I mentioned earlier, check for effective cough. You can perform a TP's trial of 30 to 60 minutes, which is also like a stress test to the patient to see whether the patient is able to breathe comfortably without any support from the ventilator. And that is a true test which can tell you that, okay, we can consider extubation. If during all this, during the TP's trial, all his vitals remain stable, his SATs remain stable, sensorium is good, there's no increased work of breathing, you can consider extubation, but you'll probably need to monitor the patient closely for maybe, definitely the next 24 hours to assess whether there's any evidence of respiratory muscle weakness, any need for reintubation, which is usually very, very rare, because the duration of need for ventilation as per the evidence is usually just about 24 to 72 hours. So I hope I have addressed all the questions that have been raised by the group with regards to ventilation in neurotoxic snake bites. Thank you, and I'm happy to answer questions.